Good afternoon. Welcome. For those of you who read the news this morning or even looked at your phone, you already know why we're here, so I don't need to introduce the session. For the person who didn't, today we want to, in fact, continue the conversation from the last session with a focus on a specific, important and underdeveloped pillar of health security, which is the information ecosystem or environment. I'm joined today by a great panel, and we're going to have hopefully a relaxed discussion throughout. There'll be a few polls where we'll be asking for your thoughts on a few of the issues that we'll be speaking about, and then we'll have time at the end for questions from you. We're going to move fairly quickly. I'm asking my panelists to only spend 1 to 2 minutes on each response so that we can get a diverse range of responses to the various questions that I have. But let me first introduce my panel. To my left immediately is Dr. Natasha Azzopardi-Muscat. She's currently Director of the Division of Country Health Policies and Systems at WHO in Europe. She's a medical doctor and is also a specialist in public health and health service management and European health policy. And she was previously a CMO in Malta. Dr. Herwig Osterman, who is joining us from Innsbruck, and that's not AI generated, he really is at the other end of that screen, is Executive Director of the Austrian Public Health Institute and Associate Professor at the Department for Public Health and Health Technology Assessment at the University for Health Sciences, Medical Informatics and Technology in Tyrol, here in Austria. He is an advisor to the Ministry of Health here with regard to structural and economic impacts of health reform, and he wore multiple hats throughout the pandemic in support of the Austrian response to the pandemic. Dr. Joe Smizer, next one along, is CEO of the Public Good Projects. The Public Good Projects is a not-for-profit organization specializing in large-scale public health communications, media monitoring, and community engagement. He leads in that organization strategy and, importantly, partnerships with major health systems and global health institutions, including UNICEF, health ministries, and industry groups. And Sibilia Kilici is currently Executive Director of Vaccines Europe. That's the European Vaccine Manufacturers Association. She was previously Director of Public Policy for Vaccines Europe at MSD. She's an economist and a statistician by background, with more than 10 years of experience in European public policy, market access, health economics, and outcomes research, in particular focused on vaccines. So, just before we start, I think I speak for all of us. I didn't mention that Joe is based in the US and that Public Good Projects has their offices in the US. Joe, how are you doing?
Hi, okay, everybody can hear me okay?
Yeah.
You can tell by my accent that I am from the US. If you're really good at US accents, you can probably tell what state I'm from, California. And if you're really, really good at US accents, you can probably tell I'm from San Diego. So what's up, dudes? It's nice to be here with you all. Surf's up. We are not doing well in the US, and I was in the last session, and it's worse than you see in the news. I'll just share a quick anecdote for you. When I'm in the U.S., I spend half my year in Europe and half my year in the United States, and I'm in Atlanta when I'm in the U.S. And something that has not been covered very widely, the most highly trained individuals at the U.S. CDC are EIS officers, our public health service officers. They have all been called back from every country that they were in, where they were the representative of U.S. public health in that country. And as the U.S. withdrew from every global health effort that we have been involved in over the years, those individuals are best and brightest in public health, usually medical doctors or PhDs in epidemiology typically, are now working in ICE facilities. So that's where they've all been reassigned. They're either in an ICE facility or in an airport, and they're the person who walks onto the plane if someone has a fever. So that tells you a lot about the state of public health currently in the United States. Everything is shifted to states, state public health, but state public health is not receiving any money from HHS or from federal health agencies. So it is, to use a US colloquialism, it's a dumpster fire. It's bad, it's stressful, and I'm here to just warn you all about what's coming.
And our focus today obviously is Europe, but as we heard in the previous session, as Joe's touched upon, events in the US, the ripple effects are rapidly making it across the Atlantic. And they're landing on the shores of a continent that, like every other country, every other continent in the world, came out of the other end of the pandemic with many challenges that we had not seen before, but in particular, and these are challenges that we've already heard in previous sessions, the politicization of public health and the erosion of public trust. And in particular, I want to underscore the erosion of public trust in the institutions that provide the health services that the public access. This was the single correlate of the impact of COVID-19 vaccination programs in a number of multi-country studies. Of all the factors of everything that the countries did, trust was the single correlate of the coverage that they achieved in their programs. Just let's set that in the background. But the first question we have to ask is, are we sure that this is an issue here in Europe? Natasha, you have an initiative with CMOs across Europe, and I think that they fed back to you when you discussed the issues, the key issues, the priority issues that they face in their countries, in their member states every day. I think they fed back to you that this was one of the challenges.
Absolutely. Good afternoon, and thank you, Angus, for the introduction. Yes, so from time to time, under the leadership of our regional director, Hans Kluge, we have been convening chief medical officers or equivalent, because in some countries you have an equivalent post holder. But let's say the person responsible for public health, often at law, right? Legally responsible for public health in that country. In terms of a loose kind of peer support and capacity building initiative. And at the beginning of this year, when we got them together, we asked them what are the topics that they want to discuss in a closed Chatham House Rules space. And they gave us two topics. One was mental health of children and adolescents and social media, because they were seeing different countries taking different approaches. And that's always a recipe for disaster, because it allows those who want to pursue their own agenda to break us up. That was the second issue. The top issue was, how do we get our heads around combating misinformation and disinformation? And we had this discussion. It was very clear that they felt that the people who work with and for them are not equipped, that they themselves just don't know how to push back, how to be able to make their voices heard. But it was interesting that we also start to hear of a phenomenon where during the COVID pandemic, public health communications in many countries were highly centralized. Were highly centralized very much at the top echelons of power, and that in some cases, public health institutes and public health leaders who often previously had quite a lot of freedom and discretion to engage with media on social media were finding themselves increasingly constrained. So this is a double whammy. Yeah. There's all of that going out there, and we don't know whether we have the skills, competencies, resources to deal with it. And on the other hand, there's also an issue where are our public health leaders in Europe still as free to speak as they were a couple of decades ago? And that's a question we don't ask ourselves enough.
Thank you. Before I draw upon Herwig's experience through the pandemic, we're going to have a series of polls, 4 polls. And what I'd like to do is put the poll up and then have you answer while we continue it, so that we're not sitting around waiting for the answer. Those of you who have been in previous sessions will see the QR code that's going to come up here. Please, we'd love to hear from you, and we'll come back and see what your responses are each time. Huig, did your experience, so it sounds like you didn't sleep for 2 years during the pandemic in Austria. Did your experience through the pandemic echo what we've already heard, and where does this issue or this challenge sit currently in Austria?
I think basically we are all facing similar challenges, and I think prior to the pandemic, when you had this kind of pandemic preparedness planning, communication, building trust was not a big issue there, and I think actually the topic is so well chosen for this discussion today, because it is not only limited actually to pandemic preparedness or the health system. If we think about trust, we have to think about an information ecosystem. I will come to this maybe later on in one of my next remarks. What we felt in the pandemic, and this goes very much to the heart of public health institutes. Public health institutes see themselves basically as independent bodies driven by science. And this is an important role as long as we work in normal times, because we are the ones that actually advise ministries, sometimes even ministries, and we advise them in a way that they always evidence-driven, but at least information-based in a way, or evidence-informed. This is our norm. The pandemic, actually what happened, and this was quite tricky in many countries, is actually, first of all, science got involved in society. This is a good thing. Sometimes science failed to be involved in decision-making. I'm not quite sure whether this is a good thing if science takes the decisions. And we had the situation in Austria where one former chancellor actually said we relied too much on science, which is a very how should I say it, a very provoking thing, at least to some extent. And usually what science is all about is actually, it's about discourse. It's about, coming up with new findings, then actually judging these findings, meeting on scientific congresses, having a debate, having different viewpoints, bringing in newer studies that maybe revise the old paradigms, and so on and so forth. And during the pandemic, actually, if science communicates that openly in the same way, science can be used for political maneuvers. And this happens. Actually, science was, I doubt that science at the time of the pandemic, especially during the first months or year, or the first year, supported trust into decision-making. And we had just one example, finally. We had a fierce debate what kind of NPIs would be effective or not, how to deal with wearing masks and so on. And this was then also taken in Austria to become a debate amongst public health professionals and a scientific debate. But it was not a scientific debate alone. It was then, so to say, it became then part of the political debate in a way that politicians approach different scientists, and so a political debate was then taken on the back of science. And this is how it should not work, and this is why we need ecosystems, basically.
Yes, thank you. So what I've heard is that this is a challenge that is at the top of the agendas of every member state in the region, and that whatever we've been doing, we haven't been doing terribly well. And it seems that you all agree that if not that we haven't been doing things well, that we are certainly not prepared to be doing things ahead of time. And so our objective today, linking back to the previous session, is to now think through what are the bold investments that we need to make in this space to start to build capacity and resilience, so that we move beyond this state of dispreparedness or unpreparedness to being ready for the next crisis of trust, of confidence, or disease outbreak. And just before we start those reflections, I would like to set the scene. So forgive me, I'm the moderator, but I've also been working in this field for a long time. I led a global program for UNICEF through the pandemic to support their country offices to manage misinformation. Here's where we are. When we talk about an outbreak, as we've heard in previous sessions, we have everything in place. We have capacity to be able to do the surveillance, to be able to understand what is the pathogen that's causing this, to analyze that, to start to develop the countermeasures, the medical countermeasures, to implement those, etc., etc. All of this is in place. When we look at this piece of the puzzle, all we do is say misinformation. Misinformation, that's all I hear. It's as if we look at an outbreak and we all sit together in our planning rooms and we say poliovirus. Ooh la la, the poliovirus, huh? Ooh, that poliovirus. Have you seen that poliovirus? The reality is that that is not the problem. The problem is, and forgive me for the infectious disease metaphor, the problem is that we are not stepping back and taking an evidence-grounded approach to understanding this challenge and to implementing all of the things that we need to put in place, just as we do for a disease outbreak. What do? What is our response? We give people facts. It's a little bit like giving people a bar of soap for a polio or a cholera outbreak. We step into every household and we hand over a bar of soap. We know that a bar of soap is not going to help in an infectious disease outbreak. We know that facts are not going to help in an outbreak, a crisis of public trust. They're important. They're a part of the solution, just as that bar of soap is. But there's a lot of other things that we have to be thinking through and doing to prepare for and address this challenge. And that's what I'd like to do today. So that's our scene setting. Trust me, what I said to you is based on a lot of evidence and experience, and we can come back to that and discuss it if we'd like to later. But I want to jump right in. So, Joe, if we could just have that first quote up, please. You've been at the forefront in the US of the application of the field of infodemiology to support public health communications in the US. What does it look like? And just an overview, what does it look like? What are the key pillars of it? And how does it work to make communication more effective? Could we have the next quote up, please?
While they're pulling the quote up, in case you're unfamiliar with infodemiology, it's the study of the spread of information. So not necessarily misinformation and disinformation. And it comes from what you all have probably heard, this concept of infodemics and infodemic management that was popularized by WHO in 2020. Not created by WHO, the field of infodemiology was a public health research field that started in the early 2000s, and then it became a practice-oriented field due to the pandemic. So WHO released a lot of training for public health professionals around the world on infodemic management. Where we are now is we need to move from infodemic management, which is basically this always front-footed concept of every day as a crisis, because we're all looking at the amount of misinformation, but you can't live in a crisis every day. That's not how public health works. So where we're shifting to now is the routine practice of how do we integrate these concepts that came from infodemic management into the day-to-day work, of health communications. So that's what my organization focuses on. Just like Angus, we are a partner of UNICEF and a partner of WHO. And what we spend our days doing is we don't have our own programs. We work within large health systems, and we focus on helping systems increase their ability to do more effective communication, more effective capacity building within the public health workforce and the healthcare workforce, and then more effective coordination. So communication, capacity building, and coordination. That's really where we are today. That's the state of what I would call infodemiology.
Great. And so I'd like to organize our discussion around those 3 points, starting with coordination, with a nice quote to kind of start us off. So, it's all hands on deck. The only way we can address this, disinformation knows no borders. And this issue, this challenge cannot be left to any one organization. Who are we continuing, so thinking about this approach or the challenge, or how do we solve this challenge? How do we better coordinate things? I think you identified in our conversation previously that fragmentation in Europe was was a key challenge. Could you elaborate a little bit on how you see the European landscape?
I mean, fragmentation became an issue quite quickly in the pandemic, you know, and this was to some extent to us a bit surprising also. Why was it surprising? Because the pandemic by nature is an event that goes beyond borders. And during the first couple of months, there was some exchanges, especially amongst neighboring countries. But this exchange actually diminished. And every country, as far as we could overlook it, established their own scientific advice committees, and those advice committees were not very much linked at that time. It might have been due to the fact that we did not meet at conferences such as Gastein, but many others, obviously, and we only had, so to say, the chance to do some online exchange, which is not that intense in a way. And what was absolutely missing, to my point, was really some kind of institutional setup. I mean, we all had tremendous challenges, so to say, but everybody tackled the same challenges in their own country. There was no division of labor in the sense that one country would focus its expertise on one topic, whereas another country, for instance, would do some research on NPI and so on. Actually, for the public health scene, there was very much improvisation at that time, and we all know actually communication is not one in it was really at that time highly fragmented. It still is, and some other things you have to bear in mind, I think, and this is because you all are in Gastein and I'm obviously in Innsbruck, not that far away. Actually, we do not have a European health union. So there is disease control is organized on a European level at ECDC that did a tremendous job. Some pharmaceutical issues are concentrated also on the European agenda with EMA that does a tremendous job as well. But we do not have a scenery that integrates, for instance, all the public health institutes also in some kind of European agency. So we are still far from a European health union that actually tackles all these broader public health issues together.
Thank you. Natasha, the WHO, one of the roles of the WHO is to convene, to coordinate between agencies, member states on multiple responses. What has WHO European Office been doing in terms of coordination around infodemic responses?
Thank you. So through our health security team, I think as WHO Europe, probably Joe, you will agree, we were amongst the most active during the pandemic, and we really used that opportunity to build up this RCCE response. But it goes beyond the emergency and the health security team, because we have been building these capacities also, for example, when we bring together the NITAG groups, the groups in every country that advise on immunization. These are a resource that are very, very important, and they need to be absolutely equipped. And I would also like to make reference to the work that we have been doing through the Behavioral and Cultural Insights program on trust and on understanding what is needed to build this trust. My plea is that we go beyond communicable disease, Angus, and vaccination, because what I am seeing is that we really need this to be far wider, and we need to take this into the area of NCDs, into the area of sexual and reproductive health. And in this sense, my internal proposal, in a scenario where we're really not going to have the resources to have all these specialized units working on their own, trying to attack the same phenomenon through different angles, is to mainstream this very much into what we need to be doing with and for the public health workforce. So this needs to be one of the key capacity building exercises that we undertake as WHO to do with our partners for building the capacities that public health needs. But I would say that even that is not enough. we need to get this to all our clinical workforce and equip all our clinical workforce, whether it's general practitioners, whether it's a psychotherapist. Every contact point with a health professional is an opportunity. But probably we can even go beyond that. We have many schools, for example, that do have programs with children, with adolescents that have some health component. It's about also enabling children and adolescents to be able to recognize misinformation, disinformation as part of the traditional sort of health and health behavior strategies that we use. So my call is to be ambitious and to go for something big and to really design a very hands-on, interactive, persuasive, evidence-based capacity building module that we can roll out to millions everywhere, because this needs to be a conversation that is taken to TikTok, taken to Instagram. And it's got to be a conversation. It's not the time where we as public health sit up here and tell you on the other side what is fact and what you should believe in. We need to be able to have some also of those very uncomfortable conversations with conviction. And people need basically to learn this and to be confident. I would say we go beyond competence to building confidence.
So we've heard all three aspects that Joe mentions, better coordination right down to, and we often think of coordination as between agencies and member states, etc., but coordination right down to individuals on the front line, coordination with communities, better communication, and better capacity. Sibylla, the other thing we've heard, I've heard repeatedly is this takes a village. We cannot address a challenge this big without collaboration across all sectors, without mobilizing everyone, getting everybody on deck. Sibylla, what have you heard from your member states? The same question from your member organizations, the same question I asked Natasha about this issue. And what is your organization thinking about doing in terms of coordination and perhaps also these other two things we've heard, capacity strengthening and communication?
So thank you, and good afternoon, everybody. I could not agree more that what Natasha said. On the national basis, so the industry side at national level, very worried of the misinformation going on, and it goes beyond vaccination. It's a war against science, and if you touch on the science, you touch right at the heart of public health and what we can deliver to the population. So very, very big worry here, and calling on us, I would say the European umbrella, to help and support. So what we do, knowing that the role of the industry with regards to misinformation, disinformation, is not so simple. I mean, for years I've been hearing, well, this is not your place, go away and take care of something else. Deliver, produce, etc. Well, I don't agree, because we have a role to play with regards to communicating science, that's, or ensuring that the science is delivered as well to the population, to the healthcare providers, to who need it in order to protect the population. So we have several initiatives, and in fact, if you go on the Vaccines Europe website in the section on collaboration, we will find all of them. One of which is an adult immunization board, which is a multi-stakeholder, scientifically led platform with the aim to really foster exchange, discussion on a scientific level in order to shape and monitor what's going on with regards to the adult immunization programs in Europe. And this is done in a, I would say, pan-European way, but also at country level. So really gathering the expertise, the scientific expertise, and aligning on what is needed to be done at European level and not siloed in countries. This is a 3-year unrestricted grant that we started in 2022, and I would say we continued basically with another 3-year grant. Another initiative that we have is what we call the Mission Board on Vaccination in Europe. So mission board, the aim was actually to mirror the mission approach from the Commission, which aim at, address significant societal challenges. And for example, they had, and also with the aim to better use the funds and the policy support in terms of targeted approach, a mission approach. And this is what the Commission has done with cancer from the previous mandate. So it was a cancer mission, which ended up, long story short, to the EU Beating Cancer Plan that has been actually flagged as a successful initiative and is used as a blueprint for the cardiovascular health plan. So we wanted to mirror that because we believe immunization needs such an approach. But there is no way you can have that in the Commission agenda. So we actually took the proactive step to build it with, as a chairmanship, the same chairman, professor as a cancer mission, Professor Walter Ricciardi, and with the aim to really highlight the policy gaps and what needs to be done in order to strengthen immunization programs in Europe here, and also to ensure that immunization remains on the health agenda, because this is not a given. And if you want to ensure that funds are actually dedicated to strengthen the immunization programs in Europe, you need to ensure this remains on the agenda. Otherwise, it's lost. So that's a second initiative. We also work a lot on respiratory infections. We have a multi-stakeholder steering group on this, which started in 2019, focusing on influenza, and today is actually evolved on the other respiratory infections, COVID, RSV, pneumococcal. And again, and here is rather to bring science to policy. So the Adult Immunization Board, very scientifically led, the Mission Board on Vaccination in Europe, to which the Adult Immunization Board is part of, very policy-led, and the steering group more from science to policy. So how we actually bring the science to our policymakers. So, and the last one, and not the least, is vaccines today.
What, can we loop back to that when we come to communication? I just want to finish the point of coordination, because what we're hearing again is that you're actively convening and coordinating to address gaps that you see. I just want to finish this piece of the puzzle with Joe. You've been doing this in the US, implementing widely in the US. I have two questions for you. The first one, it's not so much the elephant in the room, but in my experience in Europe and working in a number of other continents and other countries, there's always this shadow in the room, which is a conflict of interest or a certain allergy to collaboration across sectors, in particular with the private sector. My understanding is that the work you've been doing on this topic in the US, you have you're coordinating multiple sectors and mobilizing multiple sectors. Can you tell us, first of all, was this a barrier and what did you have to do to overcome it? And secondly, just describe a little bit that level of cross-sectorial coordination that you're doing.
I think it's something that I've heard a lot at this conference that we're all sitting in right now. It's this problem that we're facing is so much bigger than public health is able to tackle on its own. And to say something that's hopefully realistic and also, I know, a little discouraging, we're not going to solve the misinformation problem. The misinformation problem is exponentially worse today than it was a year ago. And a year ago, it was exponentially worse than the year before. So what can we do realistically? A lot of the rules that we've lived our professional lives by, in my opinion, have to start to change very quickly. And one of those rules was we have stigma built into us if you do a master's in public health and a PhD in public health, that not only should you never talk to anyone in any private sector organization, they'll pollute your water supply, but also you barely talk to anybody in healthcare. You have no concept in public health what the healthcare side is doing. So the fact that the scale of the problem and the fact that it 100% is going to get so much worse, we really need to be looking for who is incentivized for their own reasons to sit at our table as an ally and work in the same direction. So I think it's fantastical, unrealistic thinking that we can continue to have these firewalls between the perfect, untainted science that we espouse to believe in, and the other actors and organizations in our societies that have, in some cases, a lot more power and a lot more resources than public health will ever have. And don't forget, to the public health is the government. And as climate change gets worse, and migration gets worse, and nationalism and xenophobia and fascism gets worse, public health is going to continuously get pilloried by the public because you are going to look like a government representative. And the job of government is for everyone to be angry at you. So you really need community members and national partners who are not facing that level of scrutiny and anger that can maneuver in ways that public health can't.
Natasha?
I couldn't agree more. You've said it so nicely, Joe, but you've also triggered something else, which is we need to work so much at sub-regional level, at the cities level. We've got the Healthy Cities Network, the age-friendly cities. We know there are many mayors, many municipalities, and we just need to get out there a bit better. So I just wanted to jump in. Thank you.
And so I'd like to kind of make the bridge between better coordination and better communication. You're also coordinating extensively with professional associations and community-based organizations. And I mean, I've heard twice from Charlotte in this meeting the importance of us activating these actors, these people who carry the trust of their communities, who are in their communities. Joe, what is the importance of these two groups in terms of their participation, and how does this contribute to better communication?
So we're a global health organization, so half my year I'm based in the US, but unlike the stigma that is rightly carried against Americans, I go abroad often and have a passport. If you look anywhere in the world, if you talk to anyone in public health anywhere in the world, every single person in public health can tell you what are the main causes of morbidity and mortality in their community, and they can tell you who does that most affect, what community members does that most affect, and who is trusted by those community members. What organizations do those community members look to and trust, and what community leaders are out there in those communities. Let's not forget that that's where our actual power is that we understand communities and we understand stakeholders. So to me, we have survey after survey in every single country showing that HCPs hold the most trust when it comes to a lot of issues, and we have community organizations who are built around trust. So it doesn't make any sense to me that we wouldn't immediately, in a crisis of trust that's occurring globally, not just in Europe, go to where the trust lies, wherever that is. Is it a faith-based organization? Is it a pediatrician? It doesn't matter from my perspective. If good data shows that that's where trust lies, that's immediately who I want to talk to, and I want them at my table.
And Herwig, you're with us. You're right next to Sibylla.
Yeah.
In Austria, what's ongoing in terms of supporting professionals, so health professionals, public health professionals, and also perhaps community-level organizations, and involving them in health communication?
I mean, what we do have, we set up some kind of platform for good health communication more than, actually it's now 10 years ago, trying to bring in all the stakeholders relevant. And we also came up with some standards of good practice, which basically says communicate clearly, be transparent about advantages and disadvantages. Also an effort to have the media on board in a way. We are currently also partnering with our media academy in order to train young journalists about healthcare and how public health works. So there are various initiatives in place always. And what we also know from our scientific data is that it is, as it is in the US, it is the health professionals, the clinicians, the general practitioners that have the highest trust, so to say, amongst the population. And when we did the analysis in Austria on vaccination rates on a very small scale, on a municipal level, it became quite evident that the GP and the GP office has a tremendous influence whether people have trust and get vaccinated or not. So these are the different building blocks, I guess, we have now bring together. And the third, or maybe the fourth, a bit more abstract building block would maybe also partner with media and other educational institutes and to some extent also make clear to the public how science works. Science does not work in one dimension. Science is also, as I mentioned before, it is about debate, it evolves. Sometimes scientific findings turn out to be wrong. So this is a transparent process. Some do not communicate very well the whole process, how science is or how new research and new findings are created. And I think this is of absolute importance that we have a broader public knowledge in there as well.
Thank you. Can we bring up the next poll? I just want to ask everybody about one of those building blocks. We have many. Oh, sorry, Hoega, I didn't see that you're continuing. You're actually, there's fragmentation in our connection. We're just bringing up a poll. I'll come back to you in a second. While we're going through this poll, Sibylla, you were touching upon an initiative, a communications initiative that's been going for some time now. In two short minutes, what have we learned from that? What have you learned from that initiative in terms of what works in health communication?
So to go back to that, so we created back to 2011 an initiative called Vaccines Today, which is an proactive online platform to talk about vaccines and vaccination. So it's a 14-year legacy, I would say, disseminating trustful information. It has the WHO certification of the vaccine safety net, so really demonstrating that it delivers high quality and trustful information. What we did actually recently a perception survey of this platform. 60 stakeholders contributed to it, and what we find out is it's a unique platform delivering high quality content, and I will go back to that. And what the stakeholders are asking is, well, questioning whether this platform still fits with regards to the fast-evolving environment and whether there is room to strengthen it to actually contribute to the fight against misinformation. What we learned out of those 14 years of experience with this platform is there are actually key sets of ingredients that are really, I would say, important. Is about the quality of the information that is. So there are 4 of them. In fact, it's quality, it's independence, it's consistency, and accessibility. So with regards to the quality, high quality, well referenced, leveraging trusted sources. The platform is using a lot EMA, ECDC reference, but also National Public Health Institutes, and experts. We have right now the editor of this platform called Gary Finnegan in Almeria. He's been invited by the Balmis Institute for Vaccines to receive an award because of Vaccines Today contributing so much to public health. And this is a tremendous, I would say, outcome demonstrating that you can actually build a trustful platform that is accurate, accessible, and impactful, and that can also empower the communities and healthcare professionals. In relation to independence, that's absolutely critical. We need to deliver accurate information, and we all have shared responsibility into that. How Vaccines Today is working, they have an editorial board, that is fully independent. So when we say independent, while it is a platform supported by the industry, what do we support? We support, well, how much it costs to have a platform, website, social media activities, etc. So we fund that. We fund the editor, Gary Finnegan, who is writing 4 articles a month minimum, plus conducting podcasts, etc. And we fund just the travel of the editorial board to once a year, so they can actually meet, discuss, and set the next steps for Vaccines Today. Other than that, they actually decide themselves on the articles, and they do the check and the accuracy of those articles independently. So we do not have hands on that at all. And this is fully transparent. I mean, I'm sharing it with you. This is the way it is done. It is fully transparent, and this is fully appreciated and created trust in this platform. Consistency, I mentioned this 14 years of legacy, 4 articles a month. I'll let you make the math of the number of articles that minimum are available today talking about immunization, vaccines. Is over 670 if you do the math. It's probably 700 because sometimes it is more. And the COVID-19 pandemic created also a hyperactivity because this platform was significantly looked at by healthcare providers, by the citizens looking for reliable information. And last is accessibility. What we heard from the perception survey is the quality of the articles, the easiness to understand actually what the content, and the fact that it was accessible to anyone. The parents for their children, patients, or healthcare providers. And this is critical to ensure that people looking for information receive it and understand it so they can also use it for themselves. So four set of ingredients.
Thank you. And so we've touched upon a number of aspects of what makes health communication effective in terms of its impact on people's decisions and behaviors. It's not just about the what, although the what is very important. If people go out into that environment looking for answers to their questions, looking for information, and they can't find information that is relevant, resonant, in their language, that speaks to them, then they will find the other stuff, the disinformation, right, in the information voids. Secondly, what we've heard is the person, who it comes from is probably even more important than what is being said, and that we need to be considering who are the many different trusted messengers and the messengers who are trusted by specific communities. There's another piece to this that I want to touch upon that we haven't touched upon yet, which is we can't be communicating with people. The failure of our current system is that it's one-way broadcast of messages that we think are important. The last piece of this is we have to be able to understand, listen into the dialogues, the conversations around the health topics that are important, to understand the concerns, the questions, the information gaps, and of course the misinformation that's circulating. And so, Joe, handing back to you, what are you doing in terms of filling in this fundamental, for me it's almost the first piece of the flow, the workflow, in the US and elsewhere?
I liked the poll responses that we just saw.
Thanks. Yep.
There are existing networks that sometimes were created by public health, but often not, of community organizations that have organized themselves for various reasons. And every country and many communities have associations that represent scientists or professionals in public health and healthcare. How we work is we have very sophisticated media monitoring tools that are detecting public narratives in all kinds of media data, not just social media, radio, TV, the usual, around priority public health topics. When we see a signal that something is spreading widely in a particular region of interest, and so millions and millions of people are being exposed to it, we don't all of a sudden make an announcement that there's misinformation. And that's a major mistake that a lot of public health initiatives make, is they make the thing about misinformation instead about information. So what we do is, that's a trigger, and we send out correct information. We don't say we don't say inform the public about misinformation. What we say is, here's good information from WHO, UNICEF, CDC, whatever the local health authorities are, and we send that to the medical and public health associations and the networks of community organizations that we've developed some kind of relationship with. They communicate to their members and their organizations. And every time we've done this, all of the data show that it resonates much more effectively than if it comes from some 10,000 feet away perspective of a very distant health authority. And it resonates, and then it's shared more widely. If you do that, this is going to be the major challenge, I think, for health communications in the future, is right now we operate at, we all go home at 4:30 or 5. That's public health, right? So it's a 24/7 cycle of information that is bombarding any member of the public right now. And we are all going to, in health communications, we are all moving toward a more like a news or journalism model, where we need these systems that are informing us about our information environment, and we need mechanisms with the little capacity that we have and the little funding that we have, where we can send out appropriate information, because that's always going to be our strong point. We always are going to be the holders of the evidence. But we send that out to individuals and organizations who are better equipped to reach certain populations than we are in that moment. So the idea that we can do one thing a month to focus on a particular aspect of disinformation, or that we can organize ourselves at set time points, I have to say that that's going to be a woefully inadequate response. It's more about what is happening today, what do we do today, and then how do we use the knowledge that we have about how this works to proactively look at, okay, this thing's going to happen next week, this thing's going to happen in a month. What do we do to prime the pump? What do we do to get the trusted messengers ready for that? That's a whole lifetime worth of work. But it's, as I see it, it's really the only answer to our current environment.
Can we pull up the results of the poll? Because I'm interested. So we're talking about surveillance, our ability to, it's maybe not the right word in this context, but our ability to track and understand the concerns, the questions, the misinformation that's circulating. We invest heavily in disease surveillance, and it is the foundation of all of our infectious disease and other responses that we do in public health. I'm interested that 75% of you don't think that we should be doing the same thing for this issue, for the issue of monitoring and understanding our health information ecosystems.
I'll just really, there's one quick point.
Someone just answered fully core infrastructure after my comment. Oh no.
In health communications, we often, there's this kind of perception among us that some things are in the domain of journalism, but look at what's happening to journalism. Journalism everywhere is falling apart. And look at who controls the platforms of journalism. Look at who controls the platforms of media. It's a very small group of very rich old white men, right? So the idea that we can defer, oh, well, they're always on. They're always communicating. We're going to communicate at set time points once we all understand the perfect message to send. That's going to solve the problem. I'm sorry, that's just not going to work. We have to adapt, and we have to acknowledge also that journalism needs us right now. Journalism needs public health to be much more proactive and a much more proactive partner.
Natasha?
Again, Joe, you've brought something to my mind, which is something that I was dealing with in the last 48 hours. And this is how we work with our journalist colleagues or even media relations colleagues in-house. And more, I see the dichotomy between what my technical colleagues are putting forward as titles, headings, subheadings, and what our media relations team are advising. And I mean, I almost invariably tend to be coming down more and more in favor of what our media relations colleagues are advising. But many of my technical colleagues are still concerned about the subheading, the accuracy, the detail, when really what we need is that attention-grabbing headline that will allow us then to go into the detail. And we're a world apart. How do we bridge this? I mean, how do we go from a point where my technical colleagues want to call a report a title of prevalence, policies, and practice in whatever, and my media relations advisor says, we just need to call this ending. And I won't say the title of the report because, otherwise I'll give it away. But then the technical colleagues say, oh my God, but we can't put that in the title because we're not going to end this public health scourge. I don't know, I'd be interested in the thoughts, because I think that we are sometimes almost being super constrained. You spoke earlier about this, public health training that tells us don't speak to the private sector, It also tells us, be really careful before you release your information data set. Be really careful exactly about sticking with the terminology that has been agreed, because if you alter a word, is this actually hampering our ability to get into the thick of this? I don't know. I don't claim to have the health communications expertise at all.
But we've also heard that, I mean, perhaps we're handcuffed in the way we approach this at an institutional level, but we also heard that there are, hopefully this has stuck with you, that there are other channels, other communicators out there who we can activate, who we can support, and who can also be doing the communication that people need to better understand health issues and understand what the behaviors that they need to be adopting to remain healthier. I want to close the loop on better coordination. I took a photo of the what was it called, the crowd harvest, and most of the balls are in the public sector. I would posit from what we've heard today that there should be more balls in the civil society bucket, more balls in the science bucket, more balls in the private sector bucket, and perhaps individuals as well at a community level in relation to this challenge that we're talking about today. Now, the last session we heard about health security, and the aim today is to look at what are the bold investments that we can make. We've heard about coordination, we've heard about communication, and that will obviously require capacity. But I just want to finish on understanding, where does this sit currently within our health security lens? Where does this piece of the broader puzzle fit within health security, within preparedness and security strategies within Austria currently?
Currently, we are working on it in a way. I mean, as I mentioned before, we do have this kind of platform, so the people or the ecosystem to some extent is connected. There are a couple of guidelines in place. We also do some kind of media awarding for good health reporting. So there are various initiatives. What is missing to some extent is this top-down coordinated approach. And I do not only think that we need a top-down coordinated approach on a national level, we also need it on a European and on an international level. I feel that actually in public health trainings, communication does not have the place it should have. I would rather go for the argument that also the surveillance of health information is one core task, as important as the surveillance of any viruses or bacteria. So I would really be very much in favor that we see communication on the same level, actually, and information and misinformation. And to Natasha's remarks, yeah, just if few thoughts. I think that the language, but I think that science has to be aware that once a report is published, actually the media communication might have a different stance in order to make the basic and the major findings of the reports also available to the public. So these are two different professions, but the more they know from each other, the more the basic knowledge they have. So also health journalists should have some knowledge on how HTA works, on how health system works, on how health economic evaluations are done. And the same is true for scientists that also have to be aware on how communication happens in the broader sense.
Thank you. And so we'd like to hear from you now. Can we get... Do we have someone with a microphone who can start spreading that around? I put this as an introduction. So Maria Ressa, I had the honor of being on a panel with her. She's a Nobel laureate Peace Prize. When she speaks, I listen. Every single word that leaves her mouth makes sense and often challenges us dramatically. And she said at the UNGA just the other week, information integrity is the mother of all battles, which for me, coming from anyone else, could be a little bit alarmist. But I think where we are now, hearing from Joe where we're going and the speed with which we are, the acceleration with which we are racing into the future, that this is perhaps not so alarmist. And so we want to conclude with, so what do we have? What are the bold ideas, the bold investments? But let's hear from you. We've got 5 or 10 minutes for questions. 1, 2, and then 3.
Right, thank you. Svetoslav Kalashnikov, Academy of Medical Sciences of Ukraine. A lot of what we talk today is reminiscent for me of the work that intelligence services are doing while planning military operation back home. They use this I-STAR approach, so intelligence, surveillance, target acquisition, and reconnaissance. And they have systems in place to gather information from a lot of sources, analyze it, and act on it. And I would like to ask, do you see a way for public health systems to somehow learn from or borrow instruments from the intelligence services of respective countries to tackle these information challenges? Thank you.
Would someone like to answer that? I don't think we'd want to be using the same terminology.
I mean, I think what is clear to me is that what we do to date does not work and is not enough, and that we need to be brave enough to do things differently. And that might mean learning from other fields. And I think what we wanted to bring in, Angus, was also this pronouncement, in the State of the Union speech by the President of the European Commission, President von der Leyen, around having this kind of special initiative, big initiative, to combat misinformation and disinformation. And I think she went beyond health. But of course, health is security. That is clear. So probably an exchange of information to at least understand what are the options out there that we haven't considered to date and that we should consider, I think is a good starting place.
Thank you. Hoeg, did you have your hand up?
No.
Okay.
No,
okay.
I'm fine.
The
I
next
totally
question,
agree
please.
on what Natasha said.
Fula Karin?
Thank you very much. Ulla Karin Nur, Node and Dimension Partnership in Public Health and Social Wellbeing. And I actually have 2 comments and questions. First is a simple one. Communities today. You talked a lot about mentioned communities, but what do you mean by communities? When we think about how we live today, the urbanization and the communities have become really diverse, fragmented, people move around. So are we talking about, something which is still homogeneous and which has these natural leaders, or how we mean about it, how we talk about it? But now the second question. We know that to battle or to tackle misinformation, we need the triangle, the trust triangle, so that public need to trust the healthcare workers, who are the most trusted information givers, and there is also the role of the government. So the public needs to trust the government, and the healthcare workers need also to trust the government. So how can we address the government thing so that the consistency of the messages is maintained and the credibility is maintained? Because whatever we do on the other fields, it can be very easily broken by the just a little move or a not consistent message by the governments.
Which is what we heard repeatedly from Hoeg. Joe, would you like to have a shot at the communities first? Then the second?
Within public health, my training is in social network analysis. So that informs why I got into media monitoring. So I think of community from an epidemiological perspective, not literally the boundaries of a town. I think of it in terms of who is being reached by certain problematic information or good information. Sometimes there's a geography there, but sometimes there are more demographic variables that connect people or organizations than just geography. And then I think about it in terms of nodes. What nodes in those communities have an outsized impact on spreading information? And those are often community organizations and community leaders. But you're right, it's too simplistic a concept to think about this city or this nation, because you need to think about it more in terms of demographics, I would argue, segmentation, which is exactly how intelligence agencies think about it, and how epidemiologists think about it. And one quick point about the US, I know of 10 programs that were doing various aspects of looking at the information environment and sharing data between public health, and one of them focused on the intelligence community and a relationship with public health. They've all been shut down, which tells you something because the US is descending very quickly into fascism. If they shut that down in the first few months, it was effective. So it's probably worth reproducing that elsewhere.
And the second question on the trust triangle, Herwig, you touched upon the importance of our behaviors as authorities, etc., and the impact that that can have on trust. Do you have any advice or guidance?
I mean, we tackled that issue several times, and actually, I think the triangle can also be 4 pillars, as we have here in Gastein, namely the industry, civil society, government, and academia. And I think to some extent, and this is quite fine in our professional relationships, we have to have fierce debates. For instance, whether a new therapy is effective or not, whether it's cost effective or not. And in this framework, actually, it is regulators or governments that are actually to some extent also opposed to the wishes of the industry and maybe also of patient organizations. And it is good that we have these discussions. I doubt that it is always good if we have this discussion on a very public basis, because actually this is not the ground where trust can be built. Trust can be built on common goals. A common goal would be making health systems sustainable, making society sustainable, and everybody contributing to these overarching common goals. And if you focus on that, I also believe that the trust also in politics is increasing. So this is something we should always bear in mind.
Thank you. And as we go to the next question, just allow me, as a researcher and practitioner in this field for some time now, I'm heartened to see that the word trust is now part of our regular vocabulary. And I would posit that we should be valuing the trust capital we have with our publics, with our communities, as we value the health of those communities equally, because one doesn't come without the other. We had the third question here, and if we've got time, we'll go to you for the fourth.
Thank you. My name is Petra Haderer, and I am part of the Women in Global Health team chapter in Austria, but in my day job, I'm working for an NGO where we work with community health workers. So I just want to build up a little bit on what has been said here and sharing my experience. We have community health workers who work as health navigators and share information in different communities, in different languages. It's a migrants' health project. But I think we have very good experiences in this matter of trust, because it's people who really reach the people where they are, and not only do they help them to navigate through the system, but they share information, health information on vaccination and so on. And we had very good results during COVID, for example, where there was a lot of rumors around, especially in there's different concepts of health and disease and all that. So I see a lot of potential in that. Our experiences are very good. We have evidence. The fact is, we are struggling immensely with funding. It's very, very slimly funded, and we're still kind of in the corner a little bit of it's an innovative, nice project. And my question is more how do we get out of this once we saw the polls and once we hear the discussion here, and to get it really part of a regular healthcare system? Thank you.
We've got 2 more minutes for questions. Does anyone want to have a shot at that, or can we flip that to the bold investment ask that I'm going to give you? I'm not sure anyone's come up with the answer to that yet, but
I'll just say I totally agree with you. I think, like I said it earlier, if I was suddenly magically given the ability to create the solution to the problem or direct everybody, it would be, let's talk to promotores, let's talk to people who actually go and knock on people's door and know communities, and let's bring them in, tell them, and let's hear what they have to say, and then let's build programs around that knowledge. It's not going to come from Geneva. It's not going to come from somewhere else. It's not going to come from someone wearing a suit. It's going to come from someone who's comfortable walking into a bar or walking into an alleyway and talking to injection drug users or talking to immigrants, or it's somebody who knows the community and is steeped in that, because that's where reality lies.
Last question.
Yeah, Martin McKee, very briefly, just to flag up what we did during the pandemic, mainly because we've written 2 quite extensive papers that review all the theory and the science behind communicating. That was Independent Sage in the UK. So we were deeply unhappy with the official system of communicating information. We did weekly briefings, which were viewed by about 80,000 people. My colleagues had about 200,000 followers on X before we left it. And we had 3 mathematicians who have won awards for science communication presenting the data each week, followed up by listening to our viewers and answering their questions, bringing in experts from, because we spanned the range from virology to behavioral science to immunology, bring in people like Peter Hotez, who some of you will know, and others to communicate in an understandable way. And the whole point was it was a 2-way process, because while the government was communicating what they wanted to communicate, we were trying to answer the issues that were affecting ordinary people. Now, we didn't get any thanks from the British government, which is fine, but we got a lot of thanks from the Scottish government, the Welsh government, the Northern Irish government, the trade unions and local government, and civil society a lot. But we never once disagreed with the scientific evidence that the British government were putting out. We did sometimes disagree with the policy choices that they made.
Thank you, Martin. And, I mean, that's a model. It would be
just mention, by the way, on trust. We do have a book on trust. We did actually write a book on trust in the European Observatory. So, people want to learn more about it. There's quite a lot there.
Thank you. So there's some resources for you. And, I mean, this is a model. I mean, on the one hand, you ticked many of the standard boxes in what we already know about risk communication. We already knew before the pandemic that you had to communicate regularly, you had to communicate on what you did know, what you didn't know, you had to communicate in the language that people understood, et cetera, et cetera. What was shocking during the pandemic for a communicator was that many authorities or organizations failed to follow very simple principles that we know work. So they're great models. Now, I'd like to close by passing to each of our panel members, and my question for you is, what is the bold investment that you would like to make to build, to secure healthier health information ecosystems in Europe in the long term? Starting with you, Natasha.
2 investments. One, the infrastructure, the surveillance infrastructure that needs to be coordinated and fed back into the public health institutes 24/7. And the second is the capacity, competence, and confidence building to as wide a range of people as possible, as I said earlier. And I think this is doable, and it's doable fast, and we can measure the results.
And it's coherent with our last poll, which everybody voted for building, strengthening capacity. Joe?
I completely agree. I would just reiterate, let's think differently about what our jobs are in public health. All of us have this amazing ability to go out into communities and to communicate and to partner and to be an ally. We don't need to build things that we then encourage other people to join. We can join things that already exist, and we can just show up as a member of public health and say, what do you care about? What's affecting your community? What are community members saying? Okay, I know about that, I'm gonna help you. If that framing changes, I think that brings us much further toward a sustainable approach that isn't gonna require millions and millions of dollars or euros every year to hold up. And then I would finally just say, yeah, we can actually be the change for the rest of government. We can demonstrate as public health practitioners and as healthcare practitioners a totally different way of engaging with the public and communicating to the public. And I think what would happen is the rest of government would take the lead from us, rather than us following the lead from the rest of government.
Sibylla?
Yeah, so fully agree. But then what we see as well is such a level of fragmentation, quantity of activities, of initiatives that are not connected, people working in siloed. It's taking a tremendous amount of resources. So how we can actually connect all of that, and rather than reinventing the wheel, scale up what we know works, you mentioned already. And in fact, what I would like also to see happening and invest, to start as a starting point, is an inclusive multi-stakeholder forum dedicated to that topic, where every stakeholder that have a relevance in the topic is legitimate to lead on what he's supposed to deliver, but he knows what the others as well, and there is a respect between that network so that we can leverage as well our capabilities. Because by working in silos, the risk is that we basically fail. And we will not be able to leverage the capabilities that we have. So starting with this also, and I really insist on this inclusive multi-stakeholder approach, because there is room to really work together and leverage the capabilities of each other.
Thank you. And so far I've seen these are not huge investments alongside our colleagues in research and development. Herwig, the final word, what would be the bold investment that you would make?
I think it is capacity building and training, and we need some kind of core curriculum basically to be integrated into public health training. This is the one aspect, and the other one, in order to overcome fragmentation, which we obviously have on various levels, and in order to give it a broader sense, I think we need a strategic approach that ultimately leads to a program on how to devise health information ecosystems. And I see actually WHO and the European Union in the leading role for that.
Thank you.
In particular, WHO.
Sometimes there are people out there who capture a situation. I think it holds up from our conversation today. We can't fact-check our way out of polarisation, distrust and skepticism. We need to be focusing all our energy on instead of focusing all our energy on how to fight disinformation, we have to cultivate, build the systems, institutions, and norms that enable a healthy information ecosystem. I'd like to thank you in the audience for your attention and your input. Thank you so much for your time. I'd like to thank Herwig, Sibylla, Joe, Natasha for your thoughts. To be continued, I hope, because I think we've seen today that this is really the mother of all battles. Thank you.